Welcome to Same Surgeon, Different Light. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast. My name is Cherie Erkmen, and together with Sarah Pereira, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We'll learn about backstories, career challenges, and what makes each cardiothoracic surgeon unique and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons. Welcome to Same Surgeon, Different Light. Today we'll speak with Dr. Andrea Wolf. She's the director of the New York Mesothelioma Program and associate professor of thoracic surgery at Icahn School of Medicine at Mount Sinai. She graduated cum laude from Princeton and earned highest honor from Harvard Medical School. She was a general surgery resident at MGH and received her cardiothoracic training from the Brigham and Women's Hospital. She has expertise in mesothelioma, lung cancer, and health disparities. Dr. Wolf and her team at the New York Mesothelioma Program received the 2020 International Association for the Study of Lung Cancer Team Award and several other awards for her groundbreaking work in mesothelioma. She's an avid running enthusiast, having completed over 13 marathons and serving as the president of the local running group dedicated to widening our running community. Today, we'll peek behind this stellar CV and learn more about Dr. Andrea Wolf. So I have Dr. Andrea Wolf here. Thank you so much for joining us and giving us your time. And I'm really looking forward to this discussion. I think it's a little bit intimidating to look over your CV. You have a great pedigree, but I wanted to dig a little bit deeper and look at where you grew up.
Thanks for saying that. I still I'm a Jersey girl. I was born in Brooklyn, New York, but Jersey through and through, and I think the folks who have come across along the way all know that because it sort of comes out a lot. So I grew up in a small town called Hazlitt. It's in central Jersey, right near the kind of hook in the state, not far from Sandy Hook, Seabright. What I call Springsteen country. So a lot of people who know me know how much I love Bruce Springsteen, and I'm sure a lot of that is attributed to Jersey. Kind of middle class, suburban New Jersey. My father worked in the city as an accountant. My mom was a teacher. Once my little brother was born, she stayed at home. It was a great town. I love where I grew up, and when it came time to go to college, I actually had a hard time leaving the state of New Jersey, and it wasn't until I graduated college that I moved to Boston. And to this day, I joke about it took me a long time to leave the country and start traveling. And whenever I see young people who in their teens are exploring other parts of the world, I think I couldn't even get out of the state of New Jersey. How are these kids going to other countries and doing the exciting things they're doing? But I loved it, and I still do. And having come back to New Jersey in 2012, I'm very happy that I'm raising my son there.
And where did you get the notion that you were going to do thoracic surgery?
I was very, very late to the game, so to speak. I went into medicine to become a cancer doctor, as I thought of it, sort of when I was in high school, and certainly by college, and applying to medical school. I really thought I wanted to do oncology, specifically pediatric oncology. And during my pediatrics rotation as a medical student, met my first leukemia patient, who was like a 3-year-old kid we were consulted on, and thought, I don't think I can do this. And so started reshaping that. And as I went through my rotations, liked a lot of them. I knew I didn't want to do surgery. So I had made that my first clinical rotation in med school so that I could, make all my errors on surgery. And I was, to my surprise, loved it. And in fact, one of the first rotations I did within surgery was urology. And it was so much fun. And they were the funnest people I'd ever worked with. And so I thought I wanted to do urology. And I applied I actually did a sub-I in urology, spent 6 weeks at Memorial Sloan Kettering in summer of 2000, I think 2001 or 2002, and was all in. And in fact, I applied in urology and matched at the MGH and was in my first year and a half of urology at the MGH was in general surgery. And it was just before I was supposed to switch over permanently that I realized I couldn't and didn't want to leave general surgery. And that's sort of how that journey began. And this sort of critical situation or night where I made that decision was over placing a chest tube. And it was literally the week before I was supposed to switch services, and it was this poor trauma patient who had multiple issues with an open abdomen, paralyzed, sedated, and he needed another chest tube. And one of my co-residents and I spent like hours perfecting this chest tube. I mean, it took a while, and there were multiple portable x-rays done, and there were probably 2 or 3 tubes that had been inserted in between, but by the end of it all, it was the perfect chest tube. But I remember coming home that night and like looking up, it was raining. There were so many powerful things that like are so clear in my head, and I looked up and I thought, that cannot be the last chest tube I do. And I realized I liked urologist but didn't like urology. And I came in the next morning and talked to my chief resident, who sent me to the program director, who sent me to the urology program director, who said, I understand and will help you. And sort of the rest was history. And they made a spot for me, and I stayed in general surgery. And
Well, just a question about who was advising you before you even got into residency? How did you even get to medicine and make these critical decisions?
thinking back, I was definitely already interested in medicine going to college. I tried to take a step back and broaden my thoughts about it. I went to Princeton. There were lots of people doing lots of different things. I met people with backgrounds so different from mine that they really influenced my interests and sort of broadened my exposure. And I thought, maybe I want to be a lawyer, maybe I want to be an engineer, maybe, and I sort of explored a lot of different things, but I kept coming back to medicine. And I ultimately actually decided a little late, and in fact prepared to take, what they now call a gap year, or back then I guess we called it a year between college and med school. And I was a teacher in Roxbury, Mass, at the Timothy Middle School, which is, for people who know that area, it's in Mission Hill, kind of behind the Roxbury Community College. Um, I had some really great mentors. I had mentors in the university health services. I was very involved in college in the something called American College Health Association, and I was the president of the Student Health Advisory Board, and I sort of got to know the university health services leadership, and they connected me to this pediatrician in Boston because I was moving to Boston. And that guy just a very important mentor to me. He just kind of had this perspective on medicine and applying to med school, and helped advise me. And then everyone else, I think, there on in were just mentors in med school. There's a guy for people who went to Harvard Medical School, there's a man named Ron Arkey, who is literally considered an institution at HMS. Thank God, he's 95 years old and sort of still semi-working, still writes dean's letters. And I continue to see him regularly. He's still my mentor, 25 years later. But a lot of this was his influence, and he was with me throughout this process. He was with me when I, was a urology, prospective urology resident, when I was a urology resident, when I switched to general surgery, when I went into thoracic, when I took home Georgie, when my little brother applied to med school, to this day, I literally just saw him last month. So that I would say he's a major advisor and mentor.
And so during these times of uncertainty, when you're switching from urology to general surgery. How did you overcome this uncertainty?
Once something sort of hit me, there was no uncertainty. To me, I realized I wanted to do big operations, and I liked operating in the chest and the belly and big open surgery. I didn't really like stone disease and hematuria with clot retention and sort of bread and butter of urology. I always tell residents and students that they should think of every specialty and their diabetic foot. I liked vascular. I loved like big thoracoabdominal aneurysm repairs, from the subclavian to the popliteal. But bread and butter vascular surgery is the diabetic foot, and I couldn't stand the diabetic foot. And so I realized I can't do vascular. You have to think. I look at each specialty and what their diabetic foot is, and if I don't want to do that, that's not something for me. And so it became very clear to me that urology was not for me, and that I wanted to do something within general surgery. And the awkwardness of it, and telling the urologist and these people who had mentored me and these people who I really admired, that was challenging. It was one of those difficult conversations. But I went to Scott McDougall, who is chief of urology at the MGH, and he himself was a board certified general surgeon who had practiced general surgery. He had been down at Parkland, the burn unit, prior to going into urology. It sort of was a different era and how they trained and practiced. So he said, I get it. I like general surgery too. And this is what you want to do. I will support you. And to his credit, he was supportive. And the general surgeons at the MGH, and especially the residents. So my co-residents at that time were the most important people, and to this day are. And there are a lot of people, Pierre de Delva, Victor Van Berkel, several of whom are thoracic surgeons now, who were my co-residents, who were very helpful in getting me through the challenging part of that, of like leaving the urology residency.
And how do you, I mean, you've been fortunate enough to have great mentors and great colleagues. Is it just that, just luck, or how did you come to have these positive influences and positive people who stick with you through your entire career?
So I will sometimes say you do have to be lucky, and I always joke it's better to be lucky than good, to the point where my son says it to me. He'll say, I know, it's better to be lucky than good. But I do think a lot of it is just being cognizant of what's going on around you, being grounded, and sort of recognizing what's happening and appreciating those people and what's happening. We all get, and myself included, get so caught up in what we're doing, and in this sort of rush to be efficient, that we lose some of the humanity and the human contact and the recognition of the importance of the interactions with those people around us. And if you slow down a little bit and start seeing what's going on, I think you can experience it differently. And it develops those connections. You start to see the connections and kind of where they lead you, and a more natural sort of flow of life, so to speak, occurs. There's a guy named Mickey Singer who wrote The Untethered Soul, and some book called The Surrender Experiment. And his story is fascinating. The guy's a PhD in economics who became this sort of yogi and has a commune. He also happened to start the company that was later bought out by WebMD. So the guy did well. But he talks a lot about this kind of flow of life, and it's just not fighting a lot of what's going on and sort of going with it. But also staying optimistic, kind of being positive and saying, you know what, this is really hard, but I think it's going to be okay. Or, taking some blows and taking some knocks, and, having some barriers in your way, and just saying, you know what, we'll figure it out. We always do.
And so, how did you come to thoracic surgery?
So I just really loved it. I'm going to credit the guys at the MGH, specifically Jim Allen and Dean Donahue, who were operating out of Salem Hospital, um, because we went through that rotation as third years as MGH residents. and there were no fellows there. So you got to do all the big cases, and all the small cases. And I realized I really loved the pathology of thoracic surgery, like from even, from the decorts and the empyemas to the big, sternotomies and thymic resections, esophagectomies, um, managing sick patients and how to deal with myasthenia gravis post-op from a thymectomy. I loved all of it to, even chest tubes and pleurodesis and bedside stuff. And Dean and Jim were very supportive, and I really started getting excited about that, and it became to me clearer that that's what I should do. Such that by the time I rotated as the general surgery resident on the thoracic service at the MGH with uh, Doug Mathieson and Cam Wright and Henning Geisert, they I loved all of it. I mean, I couldn't get enough of it. And as the surgery resident, you were the consult resident, and I'm going to credit Chris Morse, who said if you see a consult that generates a surgery, you get to do the case, even if it's, a fellow level case. So you see a consult and it becomes, it's a lobectomy. It's your lobectomy. And so I was voracious. I couldn't get it. You would have thought I was building a practice out there. I mean, I gave all the medicine interns and residents my phone number. I came in post call. I
To
remember,
see consults.
yeah, to see consult. It was actually very good practice for New York, because like this is sort of the setting of the practice of thoracic surgery in a place like New York where there's a lot of competition. Is just being available and being nice. When they call, sure, I'll be right there. And I remember driving back, when I wasn't supposed to be there, just kind of sneaking it into whatever, because I was so excited about it and hungry to get to do this, and really just learned more and more and loved it.
You're kind of describing just a positive experience all along. It sounds like almost an unfettered pathway to thoracic surgery through medicine, through surgery. Um, but you're shaking your head. Tell me a little bit more about
Because that's the,
challenges.
I mean, those are the positive things. But the reality, as we all know, is there are challenges all along the way. And I think, probably the optimistic, positive side of me chooses to not mention the challenges unless specifically asked, or not think about them unless they're brought up. It's that the challenges. At that time there weren't a lot of women in thoracic surgery. And where I was training, in fact, there were no women thoracic surgeons, and not a huge deal, but to Doug Matheson's credit, he would include me, as he would others, in a lot of mentorship. But when I would go to these events and these things, I would be the only woman physician there. And so I would hang out with the nurses and the PAs, and I learned a lot from them. But it was a very interesting dynamic when I reflect back on it. Um, I think that's evolved tremendously. I remember going to my first STS in 2008, and Blair Marshall was my formal mentor for this STS Looking to the Future scholarship, and she introduced me to Yolanda Colson. And here was this unicorn, both of them, but here in Boston, there's a female thoracic surgeon. I got to get to know this lady. And so that was sort of my introduction to the Brigham. And as these things go, I wound up training under her, and she became an important mentor to me.
And
That's where I met you.
I wanted to get a little bit more into the challenges. So I know you're a very positive person and you want to uh, remember and reflect back on a path that has gotten to your success. But I think it's also helpful for people to hear what your challenges were specifically during the time that you were training and how you were able to overcome them.
So that opens, the Pandora's box of the kid, right? Like, when I so I was I am it's funny because I didn't even think of it until you point this out now. But I am neglecting a major part of this. I was married. I had married the first boy I met in college. I married him during med school, and we stayed in Boston largely because each of us would kind of get to the next phase in our career and stay in Boston. So, we both went there and got jobs, and then I got into med school. So when he was applying to grad school, he was being recruited by Caltech, multiple places all over the country, but he stayed in Boston because I was there. And then I was applying to residency, and I was considering options at Hopkins or Cleveland Clinic, but I stayed in Boston because he was in grad school there. And then when I was in residency, he was looking at postdoc, and we just continued to stay in Boston. But at some point during residency, we split up. And so now my entire life was work. My ex-husband had left, and this would be during my early of my fourth year residency. So a couple of things. Number one, because I had switched from urology to general surgery, and I wanted to go into the lab. Most people at the MGH went into the lab between years 3 and 4. I didn't have that option. They didn't have a position for me. Charlie Ferguson was kind enough to make a position for me in the clinical track, but he said, I need you to stay in because the numbers are that I don't know, I can't promise I can get you back in if you go into the lab. And so I went straight through, and I was at the beginning of my fourth year. The ex-husband left, and residency was hard. I had that great experience on thoracic, but that was followed by a few months of just, especially as we went into like the fall and the winter, of just rough times. And I remember being pretty miserable in December of my fourth year. So this would have been December 2006. And it got to the point where I said, you know what? Maybe I was wrong. I don't need this. I'm getting depressed, and I don't need to be depressed. I'm this happy person. I'm leaving medicine. I'm going to go work for McKinsey. This was my big plan, to go into consulting, like all the kids I went to college with who made all this money. Who needs the stress of medicine? And I had all but decided this when on New Year's Day of 2007, I started my first day of PD surge. And Chad Wilson had signed out to me, the pediatric surgery service, and I remember him telling me how cute the baby's feet were. All the whatever. This was what got him, and I go in there, and it was fine, but there was this one baby, who was I don't want to say abandoned by his parents. His parents were teenagers and themselves in foster care and had all these issues, and the state was pursuing guardianship of this baby. And the baby was, by this time, he was on the medical service, but was staying on as a consult patient for the surgery service because surgery had done so much on him. He was 27 weeker, he had neck, he had pneumatosis and sepsis, and was basically all but dead. And they had ended up doing a significant anerectomy, and ultimately put him back together. And now he was extubated on the medical service, but on TPN. He was chronically obstructed. So the baby was 4 months old. And through the course of the next couple of weeks, I was very invested in all the patients. I sort of liked the focus of being in charge on PD Surge as chief resident. There were no fellows at the MGH in pediatric surgery, so you were in charge. You sort of felt that you were contributing. And I was following what was happening to this baby. The baby, when I met him, he was in liver failure. He was like yellow, but he had just been started on this clinical trial for a fish oil source of lipids. And so before my very eyes, I was seeing him get better, but he was chronically obstructed. And the plan was always to take him to the operating room at some point to solve the bowel obstruction. But because he was metastable and sort of hemodynamically stable, they were managing him by venting his stomach, and he was on TPN. we had room to wait for the social services and the state to come in to do their paperwork to set up guardianship, and we ultimately took him to the OR. But during this time, I would see these volunteers go in and hold the baby, which was nice. But I would go through part of my process of like taking care of these patients was to look at every order. This was before the era of Epic and electronic orders, so you had to look at a lot of things on paper. And I saw an order for therapeutic baby holding once daily. And it was like a click, in my head that this was just a baby. Like, here I am rounding. I thought he was very cute. We weren't really doing anything for him. We were just coming in, checking on him, and I would report to the attendings, and I would say things like, "Oh, cuteness factor, 10." And my interns would sit there, script, and they would say, "What'd she say?" I had this kind of like, I was definitely noticing this baby, but this was the first time I realized that the needs were beyond just making sure he had his TPN and that we were preparing to do this surgery on him and following up on where the state of affairs were. And one day I snuck in there and I picked up the baby. And I remember all of this is so like, again, like so crystal clear that it was very impactful. But I remember the name of the nurse who saw me walking into the room, and I didn't want to be caught as the chick surgeon or the girl surgeon going into the room, picking up the baby. Like, it's so cliche that I didn't want anyone to know, but the nurse saw me go and she said, "You wake him, he's yours." And I pick up the baby. He's got all this stuff attached to him. He's got a central line running 24 hours of TPN, and he just, there was something. There was something. And well, I mean, as you know, that baby is my son. And it was that sort of time period when it all kind of crystallized, like everything became clear. I was supposed to stay in medicine. I'm going to be a surgeon. I became interested in thoracic surgery also during this time. Um, I'll explain a little further. The timing, by the time I became his foster mom, that's when I was working with Jim Allen and Dean Donahue at Salem. Like, it all sort of crystallized in that setting. So it was a rough time, especially before that, and there are plenty of rough times since, that I can go into detail about some of the hard times that Georgie and I have had together, and some of the challenges I faced through residency and through bringing, having a kid. As you know, being a mom or being a parent is challenging, especially as a resident and a junior faculty.
So this is a little bit of a a barrier. You usually set up a very clear border between I, as a clinician, am taking care of this person, this baby, and then you transition over to uh, caring for him as a caregiver or parent. So, how did you reconcile that transition, both emotionally and practically?
The the practical side's the easier one, because that's the one where you get to take all emotions and not think about them and be in like robot mode. So I'm kind of, I'm doing the things that I think are right. I have this sort of, that's like my North Star, always do what's right. Um, and so to me, this was part of taking care of this patient, was making sure that he had some love and some nurturing. And ultimately what happened is we did operate on him. So at the very end of January of '07, he was at that point almost 5 months old. And I knew he had resolved liver failure and that he was sort of a tenuous patient. So we had prepared to do this operation and we had booked his ICU room, and we ended up doing a stricturoplasty because that was the etiology of the obstruction, was a stricture at the anastomosis between his jejunum and his colon. We did a cholecystectomy, we revised his line, and we did a circumcision. I jokingly call it the Jiffy Lube for this baby. And we watched him in the ICU for 24 hours. The kid looked like a rose. It's perfect. And I remember I was in the operating room the next day doing a case, and my intern comes in, and as we're running the list at the end of the case, she gets a page and she said, "Oh no, Georgie's coding." So he had moved out of the ICU, had done fine, and then all of a sudden, basically had a code related to hemodynamic instability from fluid shifts or whatever it was. But I remember how I felt running up there. First of all, she said, "I'm going to go," and I said, "No, no, you stay here. I go." And as I was running up to the code, I didn't have that usual feeling that when you go into these things with that sort of emotional disconnect. Like I remember thinking, can't lose this baby, can't lose this baby, and it was a feeling that differed from my usual, patient care feeling. And anyone I could grab along the way, I grabbed. I ran into one of the pediatric surgeons not related to his care. Just this guy, David Lawler, just grabbed him just to have manpower. And as I got into the room, the NICU was there. And, given he's the size of a newborn, I, had them run the show. I wasn't kind of in that usual like surgeon, I'm going to take charge sort of. I felt like this, pediatric airway, NICU baby, like this is what these guys do. Let them do it. Can't take a chance. And as we're all doing what we do, and ultimately our role as surgeons was to do cut downs to get him arterial access, get him venous access, central access, everything to kind of stabilize him. I remember at some point someone said, "Did anyone call his family?" And several of us at the exact same moment yelled out, "We are his family." And it was myself and a handful of the nurses. And it was one of those moments where I realized that barrier that you're describing clearly had been violated by more than one person, and we were all kind of like, "All right, we are his family." And he was really sick for a while at that point. I, after we stabilized him, it was myself and Dan Duty, one of the attending pediatric surgeons, and I had called the phone numbers we had for the birth parents, and left messages and didn't hear back for days and assumed that, the father was living out of a car. I just assumed, maybe they don't get these messages. Who knows if these are real phones, right? But several days later, they called back because they had gotten the message. So they get a message that their baby is very sick and that they should call right away. And they wait a few days to call back. And, it worried me that the baby was sick to begin with. But now seeing him on the vent, really sick, renal insufficiency, you know, respiratory failure. We don't know, the liver's starting to fail again. Like we don't know which way this is going. And all these other babies in the pediatric ICU have these parents around, and then this baby by himself. And this at this point was going into February of '07 around Valentine's Day. And I was like, you know what? I'm going to do the best I can to just be like, family. And I would go there for an hour a day, no matter what time of day it was. At the end of the day, I would just sit there for an hour and like hold his hand because I just felt like somebody should do that. And I remember Valentine's Day, I bought him one of these like big, I don't know, teddy bear or frog or something, balloons. I bought it in the hospital gift shop because this is the only place where you are. So that's where you go shopping. And I like marched through the hospital. I remember walking through the hospital. They're like, "Who's that from?" And I was like, "Oh, it's for my boyfriend." Like happily walking through the hospital, and I put this stuff in his room. But this was all part of the development of this like weird relationship that I realized was, it's not something you can do all the time, um, because it's just not sustainable. As time went on, I started just accepting it. Like it was one of those things, that flow of life thing I'm talking about, not fighting something. I always remember it like felt like something was tapping me on the shoulder and I was brushing it off. I was like, get away, get away, get away. And then and I believe in God, so I'm like God was like trying to tell me something or whatever. And at some point I saw it and I realized where I was supposed to go with this, and I was like, oh, oh, I get it. I'm like, this baby's mine. Like he's my son. And one of my co-residents, John Lamatina, who's now a transplant surgeon, um, called him my son. He said something like, "Your son, blah 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 blah." And I remember thinking, yeah, yeah, I kind of just like went with it. And Pierre de Delva and I joke about it because he was the resident who I signed Georgie out to. So Georgie was still on the vent. He was still pretty sick, but seemed to be recovering. I was moving over to Children's Boston, because we did 6 weeks at the MGH and then 6 weeks on PD Surge at Children's. And they put me in charge of the short gut floor. And all of these kids looked exactly like this baby. And it was like all of these like weird little things were happening that sort of constantly pushed me towards this. To the point where I started telling the nurses at Children's, I was like, I was taking care of this baby across town. And he's on the same, and those children were all on this clinical trial for this omega-vin lipid source. And I thought, this is weird. So it would make me go back to visit the baby. And when I signed him out to Pierre, Pierre tells me that I was like, you got to make sure this one's okay. You got this baby, he's got to be okay, Pierre. You got to get him better. You got to extubate him and make sure he's okay. And Pierre's like, got it, Wolf. All right, I'm going to take care of all the patients. And to this day, we joke around about how Pierre was like, what's up with Wolf and this baby? And it sort of started to develop from there. And the nurses at the MGH would say things to me like, you know, when he is discharged home, he gets nursing care. He gets private duty nursing care through his insurance. And we could sign up as the private duty nurses and take care of him. You should take him home. We'll help you. And they started like sort of coming up with this plan. And one day I was post call at Children's. I had just seen my like third or fourth appendectomy patient, and I was like walking out of there delirious, and I get a phone call, like cold call from this woman named Pat, who was the guardian ad litem who'd been appointed by the state to help make decisions for Georgie because he was a ward of the state. And she said, he's medically stable at this point. He's been extubated, he's back to the floor. Like it's a miracle. Thank you, Pierre de Delva, for saving Georgie. She said they're looking at skilled nursing facilities, like basically a nursing, like baby can't, the birth parents are gone. The baby's got a lot of complex medical needs. He's going to be on TPN. This is where he goes from there. She said, if you know someone who would be willing to take him home, now's the time for that someone to speak. And I remember it saying, know someone, I am someone. She's like, perfect, paperwork's in the mail, blah, blah, blah. Like the nurses had already given her my address. I mean, this was like teed up like you wouldn't believe. It did
Did
take,
you ever feel like that was going too fast? That was a decision that wasn't intentional?
to me, it was so clear by this point. That was March of '07. And by that point, I already felt it, and it was already very clear. And in fact, when I talk about timelines, I always say I became his foster mom in March '07, because at that point we were doing, a home study. These people came to evaluate me. I had to get letters. If you ask people around me, they perceived it very differently. I think my co-residents were a little worried. Um, and these are people who are very good friends, who I love to this day, who said things like, I'm afraid he's going to break your heart. And I know what they meant by that. Um, I think everyone was very worried about his longevity. Um, I am still worried about his longevity, but to me, the main mission was to get him to have the happiest, most normal life he could have. And so, and I was all in, and I am all in. Um, it didn't feel fast because everything took a long time. I think the attendings at the MGH must have really thought I was nuts. I definitely think they all thought I was going to quit. My poor parents were very worried. They were worried, I think their perception was that I would have a hard time in my career, that I wouldn't have a social life. They were very, and it's funny because by this point I had brought them to meet the baby. Like I had, even before I had done the sort of conversations with the GAL and the kind of processes to become his foster mom, I really wanted to, I was trying to get as many people on board to like care about this baby, because to me it was very sad that he didn't have the family that others had. And he sort of has this like weird magnet power to him. I joke about it to this day that it's his superpower, that he just draws people in. So like I signed my mom to be like a volunteer because I had seen someone do this once for one of our patients. So I signed my mom up to be a volunteer so that she can like come in and read to the baby. And then, I had brought my parents in to like meet the baby. And God bless the nurses at the MGH because they really are the people who helped like support this. Um, but by the time he had actually transferred from the MGH to Children's in May of 2007 because of that clinical trial. And ultimately, when I took him home, it was July 9th, 2007. I took him home from Children's, and that the team at Children's and the team at the MGH continued to help me, even to this day, to help support this baby. And the way I kind of look at it is that everyone felt like his family. I'm just the one who took him home.
Was there ever a time when you did look at it in terms of continuing to be Georgie's mom or thoracic surgery, that the burden of both was so great that you would have to make a decision?
Um, Not truly a decision between one or the other, but a big juggling act all the time. One of the barriers that or challenges I faced was an attending general surgeon, not a thoracic surgeon. Actually, one of the surgical oncologists who I respected called me into his office and gave me this whole big speech at the MGH about how I should consider other careers, not thoracic surgery. I'm not going to say what those are, but there are other specialties that were not interesting to me that he thought would have an easier time being a single mom. And he basically said, I'm afraid if you do cardiothoracic surgery and take home this baby, that you're going to fail at both. And, I think it was coming from a good place. But I said, you have 9 kids. This man had 9 kids. And he said, yeah, but I have a wife at home. And I appreciated where he was coming from. But to me, it was never gonna have to be a choice. It was always gonna have to be just life is juggling. Um, and my brother and I say this to each other all the time, that you just have to figure out which balls are rubber and can bounce, because balls are gonna fall, but which are glass and are gonna break, and you cannot let them fall. And I think at any given moment, something can't fall. So to really answer your question, I think the closest I came was during the pandemic. Georgie got really sick. He got really sick, like multi-organ failure, sepsis, enteric gram-negative rod bacteremia. Like, like I didn't think he was going to make it sick. And to the credit of my partners at Sinai, they gave me the space to take care of him. And so I would say I had to make a choice during that time. It was during the pandemic, so it was a weird time. But I had to know that I gave everything I could to try to keep Georgie from dying, basically. And I also had to accept that I might not be able to, but if I knew I did everything I could, um, to try not to let him die, then I'd have to be okay with that. And that sort of mentality was the same one my chairman had, in kind of forcing me um, to take the space. And he basically called me one day. I was in the OR. Georgie was in the ICU, and I was in the OR. And he said, What are you doing? Like, you need to focus on saving your kid." And I think I am lucky, and I think I am very grateful for that support and that space and the protection of my partners who helped. My partner Kim Song covered me during that time, and that I would say that's the time that I really did have to make the choice that you're describing. Um, but I think we all face that at some point or another, or something like that, whether it's a parent, God forbid, a kid, a loved one. or even ourselves, where we have to prioritize things differently than we would have expected, and you need to do what you need to do at that time. And thank God it worked out. But life's kind of like that, where there are times that are going to be bad. Um, Not to quote Bruce Springsteen, but if I got through an entire discussion without mentioning specifics, there's uh, the song "Wrecking Ball" has some thing where he goes back and forth. Hard times come and hard times go, and Georgie has now gone to a series of Bruce concerts, and he knows every lyric to every song. And I remember seeing him sing this part of the refrain with me, and the two of us together, kind of, typical Jersey fist pumping, but that's hard times come and hard times go, and hard times will come again. That's part of the song, and I think there's a lot of truth to that. But knowing that we all go through that, that's part of the human experience and the human condition, you know, sort of helps me function.
Fast forward to today. Um, how's Georgie doing?
Thank God. Generally well. I always call it tinkering. There's a lot of like ups and downs, but he's 18. He's like full size, like 170-pound adult, like taller than I am. As my chairman Flores says, body by TPN. He is in school. He's got friends. He plays sports. Um, he's currently trying to arrange a date with a girl he has a crush on. Um, and he's a great kid, and he's obnoxious and thinks his mom's really annoying. Um, and I guess sus, which I don't know, those with teenagers may understand. I'm getting a sense that it's sort of insulting, but there's something kind of cute about it. And overall, okay, it's just it's ongoing work for both of us. The medical stuff is a little more natural than some of the day-to-day, challenges of helping him develop emotional strength and try to navigate the world. He's, same issues that we all have, arguments with friends or feelings or, all the usual stuff. And I am so thankful when he's obnoxious to me or when he's struggling with the same kind of stuff other teenagers are struggling with. I think we are in a good position because this
It's a
kid,
privilege, right?
yeah, it really is a privilege because if he's able to mouth off to me, he's not fighting for his life right now, which is I'd always take that. And it's it's really cool to see uh, the amazing man he is growing into be. I want to help him figure out what he wants to do in life and help him find fulfillment and have that clarity and love what he does because I think he's actually very bright and really creative and really funny. And so I want to help him figure out what he wants to do, just like we all do.
So when you're focused on Georgie, his maintenance of his health and his future, how do you keep your own identity? You're a thoracic surgeon, you have your own patients, your own needs, your own career ambitions. How do you keep your identity when you're a single mom and taking care of Georgie's needs?
They're so interrelated. I mean, that is part of my identity, and that's part of who I am. And he is so accepting and sort of, whether it's making fun of me or getting angry at me or appreciating me, um, the fact that he recognizes who I am sort of validates it. A lot of what keeps me sane is, focus on running and health and exercise, and this sort of helps sort of become a framework that sort of everything else hangs on, and so that's probably the biggest part of it. Like if I start my day with a good run, everything else just falls into place. And that's a big part of how I would say keep my identity in this, but I don't see them as disparate. Like, I don't see myself getting lost into this role of caregiver. It's just all part of it. They're sort of different sides of the same coin.
I wanted to ask you, as we wrap up, we could talk for the whole afternoon, but we always try to pose this question to people who we interview, which is, given your experiences and where you've seen thoracic surgery evolve during your time, where do you think we're headed?
That is a great, great question. So what I see, not just for thoracic surgery, but for all sectors, is younger generations, especially having experienced the pandemic, um, are focused on the big picture, and the big picture includes sort of sustainability and well-being, and sort of a bigger picture of ourselves than just what we do at work. And I see well-being as being a bigger part, uh, I think it has to be a bigger part of our specialty and a bigger part of focus in order to maintain the workforce. That if we sort of bury our heads in the sand and say, we don't need to worry about, OR-related musculoskeletal disorders, and we don't need to think about interpersonal relationships or life outside of the OR, or our own physical health, I think we're doomed as a specialty if we ignore all of those things. And so I do see an improved focus on issues related to well-being, or even issues related to burnout, its sort of counterpart, um, that I think will actually help our performance. I think that what I hope to do is drive this change in culture where we accept that we're all human beings. We need to eat, we need to sleep, we need to talk to people. And that if we can help support that side of ourselves and each other, I think that will improve our productivity in the long run. It will certainly help maintain the workforce, because I think younger generations of physicians are not going to want to go into our specialty if they continue to view it the way it was viewed 20 years ago, where you commit to this, and if you're a woman or interested in a family, or a man who's interested in a family, or something different than the sort of stereotypical picture of what we showed you for the last 100 years, then this is not for you. I think that's not going to work going forward.
Right.
And I think that's okay. I think that focusing on this stuff is not as hokey as it sounds. I think it actually, data from medicine, surgery, and other sectors show us that the people actually perform better. I wish I focused on this more when I was younger, when I was a trainee, because I think that would have actually improved my performance then.
And I think, y- like you had, having a community of people, both within thoracic surgery and around your family and around your work, to support people like you, so that we can bring your brilliance, your skill, your exacting way with research and patients. We wouldn't have that if it weren't for the people who supported you. So I think building this community and knowing that there are people with very different backgrounds and a lot of different perspectives to add to thoracic surgery. So you're a testament to that. So thank you so much for sharing your story. It's been very emotional for both of us. But I really am so thankful that you were able to open yourself up, as your story is so unique and so inspiring. Thank you for your time.
Thank you. I've been the beneficiary of that, and I have to tell the story that I am the direct beneficiary of you as a role model, as a surgeon and as a mom. when I met with Dr. Sugarbaker to apply to residency and working with him, he introduced me to you, and you had just had your baby. So he must be about 17,
He's 16, yes.
16.
The original sugar baby.
Yeah. But he made it a point. Well, Cherie here just had a baby. You can do it too. And it was true. So thank you for what you're doing and for the for your work and what you highlight and the community you help create. So I've been the beneficiary. I hope to also contribute.
Thank you again.
This has been Same Surgeon, Different Life, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. More information about the Society of Thoracic Surgeons is available online at sts.org.